everybody. I'm going to holler because I don't want to take the mic away from Jim. So, you hear me okay?
Yes.
Okay. Welcome to our first Insights of 2024.
Yay.
We are very happy that Jim Marks has accepted our invitation to do this. He has a very colorful resume, as you've probably seen. We have set him up with a halo today, as you can also see, because we needed a little bit of light for the video camera. So he's going to speak for about 40 minutes and then leave about 20 minutes at the end for some question and answer. And he'll tell you about his life and his life with Judy and his children and his career. So please welcome Jim Marks.
Thank you. Good afternoon. As you've heard, my name is Jim Marks. I'm saying that partly for the camera because I have a mic on. Can you all hear me all right? Those in the back? Good. Many of you already know me as one of Chica's assistants or as a somewhat quieter person often sitting next to Judy. Today I'll talk a little bit about my life and career and how I ascended to those positions. And before I do, afterwards or even during, there are a number of books and publications that I either supported or was involved in. A few reference me, some do not. I could have brought many more that do not, but that's as you would all expect. Let me begin with the conclusion. With apologies to Jimmy Stewart, I have had a pretty wonderful life. Born into a good family, have a good family, had an enjoyable and fulfilling career. The rest is details, but I'll give you some of those. Before I do, I want to, and I'll read this to you, so the ones in the back might not be able to. I want to give thanks to Becky and anyone else involved in the decision to invite me and to all of you for coming. The cartoon says, and it was so typically brilliant of you to have invited an epidemiologist. I am a pediatric epidemiologist with a career in public health research and health policy. I'll touch on a variety of things, but also feel free to ask questions any time during the talk. And I hope there'll be time at the end, as Becky mentioned, for conversation, questions and answers, whatever. I grew up in Alden, New York. It is a small town, rural, outside of Buffalo. My family, we had 6 children, and I was the oldest of 6. My father was a country doctor. He did house calls, had evening hours, Saturday morning hours. He was paid occasionally with chickens and corn and apples as they came into season. My mother was very different. She was an artist. She started off as an interior decorator, painter, piano player by ear, a local performance in amateur theater, and later became an art teacher. But the biggest event in those early years was that I transferred from the Catholic elementary school into the public school in 9th grade and happened to sit behind one Judy Marks, then Judy Mack, alphabetical seating. I don't think it'll spoil the plot, but eventually we married. And she was the smartest and most popular girl or young woman in our school. And that's scientifically provable. She had the highest grade point average. She was elected president of the class 3 out of the 4 years, and the one time she wasn't, it was a guy that was elected. She was also one of, if not the nicest young women in our school. Probably not as provable, and certainly not by me, because once I started spending time with her, I spent much less time with the other nice girls in our class. And lastly, she was the prettiest. Not provable at all, but it doesn't matter. As many of you know, beauty is in the eye of the beholder. And she was also independent and somewhat adventurous. Fortunately for me, we went to a small high school, so her options were limited. This is a picture of Judy from the Sunday magazine of the Buffalo paper. She is seated on an array of the academic colored hoods near the graduation time for the State University of New York at Buffalo. She had just been recognized as the outstanding freshman woman at the university. I went away to a small, pretty, and demanding liberal arts college, Williams College, in Western Massachusetts. Like most kids, I grew up a lot when I went to college, and I've gone back to a couple of reunions, and I found that many of my friends have also matured reasonably nicely. But the most important thing I learned at college was that though I was smart, I was not brilliant. And that awareness has served me well throughout my life. I went to med school at Buffalo. For me, medicine was the best marriage of science and helping others. And that's really what I wanted to do. I had good role models in my family, and that helped. I loved all my clinical rotations, the seeing of patients, and decided to go into pediatrics. Judy and I knew we would be happy to stay in Buffalo. And the only thing that could change our plans would be if I could get accepted to a residency in a cool city. And we did, San Francisco. And had a great time there, and I'll tell you a little bit about it. Judy by then had her, of course, bachelor's degree, but she also had her master's in guidance counseling and was able to get a job as a middle school counselor there. This is a picture of Judy. About that time, we were in San Francisco. We loved it as a city. This a picture I took of her when she was flying a kite in Golden Gate Park. It's one of my favorites. It was in the 1970s, so there was still a little bit of hippie glow, and it was a fun place to be. We loved the outdoors and the many different cultures and cuisines in San Francisco. The training was good, and we made many friends there, some of whom we stay in touch with. This is my picture from around the same era. Some of you may have noticed some changes. There are many adventures we had, and I'll mention a couple very quickly. We went camping with some friends in Northern California, and on the way, heard about a People's Fair that we thought we would stop in. It was quite busy, and so we had to park quite a ways away and walked in with the other couple. We were the only ones with clothes on. That was the San Francisco at that time. We joined with house staff and nurses to rent a ski cabin up in Lake Tahoe for the whole ski season. And of course, when you're in residency, you have night call, but the weekends we didn't have call. We would go up there, and some would downhill ski, some cross-country ski. The number of people depended, if there were more than there were bedrooms, you slept in a sleeping bag on the floor. It was great fun. And with Judy and I both working, we felt like we had money for the first time. She had worked while I was in med school as a teacher, and then a part-time guidance counselor and teacher. We made do in medical school, but for the first time, both of us earning about $10,000 a year, it felt like a lot, even in San Francisco. I'll give you another quick story. Because Judy was working and I had some scholarship assistance, by the beginning of my senior year, we would not have had to take out a loan for that year. So we decided to do so anyway, and we spent it going to England for a month. That, one of the better moves we've made with money. So while I loved pediatrics, I had several experiences that moved me toward public health. Every doctor has individual patients or experiences that stick in their mind and influence their career. I'm going to touch on a couple. The very first patient that I had to examine on my own as a med student near the end of my second year, while still taking the classroom work, was a 16-year-old girl with a newborn baby for her first visit after having the baby. It turned out the baby had not reached back to birth weight. It was still below its birth weight. Her parents had disowned her. She was living in a very small apartment. She had no support. In asking her about the baby, I said, "How is it eating?" She said, "It seems fine." And I said, "How often does it eat?" She said, "I feed it 3 times a day, like me." Those of you who've had babies know that that's not enough. I said, "Did it cry much?" And she said, "Yes." And I said, "When a baby cries, there are 2 things you should check. Its diaper and whether it's hungry." But then I went out and got the nurse, and I said, "This young woman is going to need much more help than a 30-minute visit. We've got to set it up that she gets the kind of support that she needs." That was not something that I was either prepared to do or anybody was normally prepared to do. And I knew that no matter what we did, she was unlikely to have a very successful life, nor would her baby. Then we went to my residency in San Francisco, and I had a friend, one of the first nurse practitioners, and she was working at what was then called the Florence Crittenden Home for Unwed Mothers. These were homes where young women, usually 16 to 18, because they were a little bit able to be independent, came with their newborns, usually when they were estranged from their families. And she asked me if I would start to see the babies, and then asked me if I would start to see the mothers as well, because they were of the pediatric age group. And it was also very clear, so they would turn over their welfare checks to this home, and they would get $5 a week for spending money, and 50 cents more if they helped with the dishes or other chores. I started to ask the mothers, most of their babies were reasonably healthy, I started to ask the mothers what they read for fun. And if they said anything, I knew they were doing better than most. I asked them what courses they were taking. And if they wrote it out, like social studies instead of SS, I knew they were doing better than most. I was discouraged for their chances as well, long term. So then I started to volunteer at the Planned Parenthood Teen Clinic in San Francisco. There were nurses, and teenagers were some of the assistants. And naturally my hope was that by providing contraception we could prevent more young women being in the circumstances of the ones I was caring for. Our daughter Amy was born in San Francisco, and near the end of our time there, and she now works at St. Joe's Hospital here as an anesthesiologist, so we're fortunate to have her. In San Francisco, I learned about the CDC having disease detectives, and I got interested in that. I visited a friend there, a friend that Martin and Beverly Myers know well, Walt Ornstein. He had been a year ahead of me in residency and was there. And he was working on immunization, and I talked to people there, talked to Walt, and I felt anything that was that much fun, paid better than a fellowship, and it could be useful, what I would learn there, if I wanted a career in academic pediatrics. So I applied and got in to what was called the Epidemic Intelligence Service. Disease detectives is sometimes how people hear about it. I was assigned, I'm now sorry to say, to Columbus, Ohio, and there at the state health department. But it turned out to be a great choice because Ohio had a lot of disease outbreaks, though it was a huge change from San Francisco. And in fact, when we got our rental car to start to look for places to stay, the first thing we heard when we turned on the radio was that it was a great day for hay baling. That was different than what we heard in San Francisco. Judy had a new baby there, and she was so lonely initially that when the Jehovah's Witnesses came to ring on the door, she invited them in. As I said, there are a number of books there. They'll tell you stories about disease detectives and things like that. And while I had quite a number of stories, I'm going to stick with just one. Near the end of my first year in Ohio, I got sent to an outbreak of German measles, rubella, in Hawaii. And that's important. German measles itself is a mild illness, but if it comes early in pregnancy, it can lead to very severe birth defects. And that's why the vaccine was developed and why it was important to get. This was in 1977. The vaccine had been developed in 1970, and it was tested, field tested in Hawaii, but nobody knew how long it might last. And the people getting ill were young adults in their early 20s. So there was real concern that there would be a large number of babies born with birth defects because of it. There are a number of things you do when you go to an outbreak, and Hawaii is a small state. It has some good capabilities, but they didn't have the expertise that they needed. I got met at the airport, and the first thing that happened before I got to the hotel, before I got to the health department, well, I was taken to a radio talk show to talk about the epidemic. Remind you, I'd not seen a case, I'd not talked to anybody about it, I didn't know what the results were, anything. And as you might expect, I got a lot of questions, and yet I had to sort of waffle a bit on some of the answers. We got into the health department, and it turned out that while they had been gathering information on the cases, and they were just putting them in a box, they didn't do any codification of the date of onset or the age, sex, where they lived, anything like that. They did have some questionnaires about things that had gone on in the 2 weeks earlier, which was the incubation period. So we had to do all of that organization. The state epidemiologist, I'm going to say this, but he turned out to be very helpful. He was a bad alcoholic, and so he would come in late, and he was able to be talked with in the morning, but he would start drinking at lunchtime. So we set it up that twice a week he would meet with the State Medical Society and leadership at 10 a.m. We'd get him to come in at 9, we'd brief him on what was happening. He would do that, and he did well, and that allowed us to avoid much criticism that might have happened later. One of the things we wanted to find out was where this exposure happened, because what we saw was a huge and rapid peak of the cases. And we knew that the exposures would have happened a couple of weeks earlier. Well, it was a big weekend. There was the King Kamehameha Day parade. We found out that many in this age group would go around to discotheques, and on the Saturday night, Friday night, whatever. So we started to do a questionnaire. It was all landlines. We could find the phone numbers that were in the apartments or houses next to the people that became ill. And we called next, either side, close, a little bit further, until we got someone of the same age and sex. And we asked them the questions that we had asked of the cases. And we found that many more people went to a specific discotheque, the Point After discotheque in a hotel. We went there, talked to the people, found out that the piano player at that discotheque in a band was centrally located and had been ill. And he was the one probably to spread it to many. We later were able to publish this investigation under the title Saturday Night Fever. We also set up clinics to get as many people as we could vaccinated so that we could prevent both further spread but also further risk to further pregnancies. Not all outbreaks or epidemics can be solved, but that was one that was both great fun and worked out well. I left CDC after those 2 years to go to Yale to see patients again, because I wasn't sure I wanted to give up seeing patients, and to get my master's in public health. I learned more statistics and the intricacies of study design. Adam, our son, was born in New Haven. He is now on the University of Michigan medical faculty as head of training for palliative care and hospice work. Judy asked, while we were in New Haven, that I find a place where I could stay for a while, since we had moved around quite a bit and been in 6 states by that time, that our kids could stay and grow up without us having to move. We thought CDC would be a good place, and found that I liked public health research and the implication that it could be useful for many, and that research could influence policy. Let's see. There. This is the family now, or not now, but not too long ago. You see Amy on the far left and Adam on the far right. That's when we were at Machu Picchu in Peru. It was a great trip, and they climbed that peak in the background. And also, by the way, my mother's family is from Peru. So on that trip we saw relatives. At CDC, we spent 24 years, lots of positions over time in the agency. My time in Ohio, and I worked part-time for the state of Connecticut's health department while at Yale, gave me a perspective on what state health departments and local health departments needed to do a better job of disease prevention and control. At CDC, I helped to start what were called the health behavior surveys, behavioral risk factor surveys in each state. It allowed comparisons across states. So for example, this was one of the ways that they found the impact of tobacco taxes, higher taxes in some states, on use rates. They found that people who would admit that they may have driven after having too much to drink was 6-fold different in some states versus others. That there were higher rates of mammography in states that had laws that required insurance companies to cover it. Now it's probably the largest survey in the U.S. with 300,000 or 400,000 interviews a year. It's used in other countries. I wanted to use that as an example because this is one where I might have been smart and not brilliant. We had colleagues where I was working at CDC who were doing single one-time surveys, and they couldn't keep up with the interest on the parts of the states. But they would do one, and then that state wouldn't get another one. And so it was my thought that we should try to find a way to routinize this and have all the states do it in a systematic fashion. And with them, I wrote up the proposal that got funded to allow us to start that. I later, shortly thereafter, became head of reproductive health at CDC. My background probably in Planned Parenthood and teen pregnancy probably helped me. There I started surveys of women who had recently delivered. And one of the things there that we asked in those surveys, and it's now in almost all the states, if not all, was if the women who had delivered had ever been physically or sexually abused in the year before they delivered. And it turned out that the percentage, and this was the first population-based survey, there have been surveys in emergency rooms and things like that, that more women had been physically or sexually abused in the year before delivery than had gestational diabetes. That was a surprise to many, many people. We were also asked to look at the issue of assisted reproductive technology. It's sort of in the news now. That was growing rapidly at that time. There were a variety of the ways the clinics would show that they were good. So some would report their pregnancy rates, 80%. They didn't report that many of those women would have a miscarriage very soon after becoming pregnancy. Others would report other kinds of intermediate steps. We, working with the field, were able to create what we call the most important measure, and they all use it now, the take-home baby rate. So that if you get pregnant, what's your chances of having a baby that you can take home. And we allowed them to adjust it for the age of the woman and things like that. It transformed the field. It allowed people to see which clinics were doing well or well with what groups. As you may know now, it's probably 40 or 50,000 pregnancies a year, maybe much more. Eventually, I was selected to be the director for the Center for Chronic Disease Prevention and Health Promotion at CDC, one of the large centers. Among the programs there that I got involved with was we found from the surveys that I had mentioned that women of low income or minority status had much lower mammography rates than those that were white and well off. And so we started to ask Congress for the resources to pay for mammography for low-income women. And we eventually got those resources, but I remember, again, being smart but not brilliant, going up and talking to a staffer who's a good friend now, and pitching what we could do about public education and those sorts of things and getting information out to the women. And she said, "Are you going to pay for the mammography?" We said, "Well, CDC doesn't usually pay for health services. That's more Medicaid or others." And we talked some more and how the things that we had learned, and we did it all. We also talked about cervical cancer, which still kills about 4,000 or 5,000 people a year. And she said, "Well, would you think you'd pay for these tests?" And I said, "Well, it's not really our role." And then a little later, she said it a third time, and I said, I knew what she was getting at. Yes, we could. We would need some help, and we could probably make it work. It was clear that we weren't going to get support unless we were willing to pay for the mammograms, and she was very nice not to tell me that directly, but to hope I could figure it out. And unfortunately, I did. Another area in cancer was that there were a large number of women in an area of the state of Vermont who were being diagnosed with breast cancer. And they wanted to know, was this more than normal, or just now we've got some good doctors who are reporting the cases? And I had to tell them, I was talking to the staffer of the representative in Congress, and I said, we can't tell you for sure because there's no registry. New York State has a registry that you could follow and determine the number of cases. And Connecticut has a registry, but most states do not, and Vermont did not. And so we have no way of knowing the number of cases before or what would be normal. And that staffer, a young woman who's now a friend, was working for the then lowest ranked congressman on the Hill, Bernie Sanders. And I didn't know who he was other than he was an independent. And so all the Republicans and all the Democrats got to assign their people to committees. He was an independent, and so didn't have any of that authority. But she was really smart and knew how to encourage other people in other states to make sure that they got credit for getting the law through, and we eventually got support for a law to set up population-wide cancer registries in every state. One of the first places to do an interesting analysis was Michigan with its new registry. And they found that the proportion of breast cancers diagnosed early was much different in some areas of the state than the others, UP and other areas. And with that, they started to decide how to target some of the resources and education that they had to improve the rates overall. I retired in 2004 from CDC as a Rear Admiral in the Public Health Service and Assistant Surgeon General. So at that stage, I was sort of the highest ranked career person, the highest level. I reported to political appointees. And I'll give you a quick story of what that could be like at times. I was being asked to go up. The then Secretary of Health wanted to set up big tents where people could be screened for diabetes at events like state fairs, the Sturgis Motorcycle Rally, and things like that. And we were heading up on the plane from Atlanta, and myself and the head of the diabetes program, and I said to him, Frank, you cannot tell them it's a bad idea. You can say, what are we going to do when the American Diabetes Association recommends against it? You can say, what are we going to do when the Preventive Health Services Task Force recommends against it? What are we going to do when Medicare can't pay for the testing because they can only pay for medical tests for people that are ill? What are we going to do when they don't have the ability to contact the doctors? You can say all of those things, but you can't say it's a bad idea. That's the level that I was at that time. After I left CDC, I went to the Robert Wood Johnson Foundation, where I had a wide-ranging responsibility that I enjoyed greatly. It was less money to spend, but much greater flexibility. And one of the things we set up was a means to rank the health of every county in the U.S. and then compare it, not just on health, within a state, so you could see which county was the poorest in the state and which were the best, and tie it to key variables, which I'll touch on. This was another good idea, brilliant idea, thought up by a friend. And when I was at Robert Wood Johnson, he had done it in Wisconsin. When I was there, he called me up and said they wanted to do it in 5 more states. Would we be willing to fund them? And I said to him, Pat, if you can do it in 5 states, it might be possible for you to do it everywhere. Let's give you a planning grant to see if you could do it, and that there was enough information on all the states to do it there. And he came back about a year later and said, there's enough information. So we set it up that we would report on the health of every county. We used life expectancy and years of life lost, a means of weighting younger deaths more. So deaths to young adults, to infants, would weigh more than a death to a person much older. I won't go into that too much. And in the first wave, Pat had told me what happened in Wisconsin, that there was a lot of hue and cry. It's almost like grief. People first criticized the act of doing it, then they criticized the data, and then they got angry, and then they grappled with it. And he got called in by the health committee members on both sides of the aisle and could talk to them about it. The health department, the county that had the worst ranking, called to complain, but then they called back and they said, we had a meeting to discuss this. In the meeting, I said to the people, he said, we had 200 people there. If I had had a meeting before, I would have been surprised if we'd gotten 15. He said, I had to say to them, hope is not a strategy. What are we going to do in our county? And those are the kinds of conversations we wanted to have. And the thing that most predicted or correlated with the health of the county overall was the percentage of children in poverty. We measured things like that, employment rate, as well as obesity, tobacco use, percent that had health insurance. Those are the kinds of data that we could get. It got a tremendous amount of attention, and it got us to focus somewhat more on what we then needed to do, and some of these are reports. We then created a commission to build a healthier America, and the whole purpose was to look at the social factors that greatly affected health: education, housing, income, neighborhood safety and development, the role of anchor institutions. Think of it here like the university is an anchor institution for the city of Ann Arbor. And we had people from healthcare, but we also had people from industry. We had Walmart, Sirius XM Radio, from the media come to be part of this. And we learned a lot, they learned a lot, and created, as I said, some recommendations that have then turned out to be useful. It turned out that that helped generate what is now a lot of interest in the social factors and how they relate to health. It is not just that they relate to health overall. People who have serious illness, if they come from a low-income background, like those where they weren't screened for breast cancer, they don't do as well. So how do we bridge that gap? Also there, yes, thank you. We started to support the whole area of public health law. A friend of mine had been the lawyer for the health department in the state of Georgia. And she said we had to review pending legislation. She said, I had more potential laws to review than any other department. If it related to agriculture, was there going to be a health effect? If it related to the environment, was there going to be a health effect? Naturally, health care, naturally things like tobacco, but all these other areas. You have to think of law as the scaffolding a society uses to build what it wishes to become. If something is already the way we like it, you don't have a law. You create a law to help move society toward that direction. If we thought health was important and important for everyone, we needed to create the policies for that. So now how did we come to Michigan and Ann Arbor and Glacier Hills? Our grandkids are here. And so we came after I retired from Robert Wood Johnson Foundation to be near our grandkids. This is a picture of them when we're on a picnic during COVID, because of course you couldn't be close to them. So we played Frisbee and things like that, and we could take a picture out in a park. I wanted to comment. We like being in a college town. There are interesting people. We like being at Glacier Hills because there are so many interesting people. We came to Glacier Hills probably a little earlier than we might have. I have a family history of Alzheimer's disease, and I have some of the genetic precursors, so that my risk of eventually having Alzheimer's is higher than normal. We also could bring Chica, and we could deal here with potential health challenges down the road. In both Ann Arbor and Glacier Hills have been good moves. Thank you.